They are slightly expensive, maybe around 1000 or 1200, but then they are available. The urologists, they use the ureteric catheters or the stents. The same company manufactures these are PTFE material and less allergenic. So this suture I am taking intermittent, and I might remove if I feel it is a circular opening. I prefer to have an oval opening or a fish mouth type of opening of the meatus. So this is the suture which I take. You will see that it is looking fish mouth. And immediately there is a curling of the tube which has started. If you see, the epidermis is going in. So when we used to witness Professor Asopa's workshops, we used to get scared as plastic surgeon because he used to use 21, 22 number blade for taking incisions, and he used to go very swiftly. I have a smaller forceps. So these sutures have to be in the dermis, and then I am taking them as stay so that there is a rolling in of the tube. So this becomes slightly helpful, especially when you have very thin tissues. Suture like, and then start continuous sutures. So it's an individual preference, which suture, which type of technique, and whichever you are conversant with consistently good results. I think that is a good technique.
You are using a monofilament
PDS. 5.
Any difference with the use of suture material in fistula rates as compared to Vicryl versus PDS or monofilament?
Vicryl, somehow the gliding I felt is the issue. Initially we didn't have PDS, then 30 years back we used to use even chromic and then Vicryl. Then we realized that the tissue doesn't glide and there is a trauma definitely when we are observing under loop magnification. And then we shifted to the PDS continuous.
See, the another reason of using PDS is that earlier when PDS and Vicryl both were not available, only catgut was available when we were using it.
Yes, sir.
So catgut dissolves in about 10 to 12 days time. So it may be little early as far as reconstruction is concerned, but tissue is to heal, and I don't blame the catgut, really. We used to use it.
Yes, sir.
Then came the Vicryl. Now Vicryl overstays. It stays for 4 weeks. That is not preferred, ideally, scientifically. Then came the PDS in between, 2.5 to 3 weeks. It takes time to dissolve. So it ensures also that wound healing as well as it doesn't overstay. That is why PDS is in between and it is preferred.
So the dictum is we don't see the epidermis when you are doing tubularization. These sutures, these bites, they could be transverse, oblique, or you can take bites which are parallel to the urethral plate. So depending on the tissue availability, you see that the gliding is good.
Hello.
Yes, sir.
I am through with the surgery. I have sutured the bias flap in the midline.
Yes, sir.
Now I am going to give a very light tire dressing here in the midline. Okay?
Yes, sir.
Yeah. This
Dr.
complete
Mokal,
margin-
Dr. Mokal, I have a question for
Yes.
the audience.
Yes.
When do you release the tourniquet?
Immediately after doing the tire dressing.
So if there is any bleeding as after excision of body or transfer of
I am going to give a good tight dressing
yeah,
here.
I understand that.
Yeah.
Just for the beginners,
Yeah.
is it advisable that you take care of the hemostasis also, before giving the tire?
Yes. Yes.
Because a lot of dissections, especially on the glands, which bleeds heavily,
Yes.
and then even after body correction there will be some oozing.
Yes, sir.
So that is why I asked.
That's fine.
Very nicely the two preputial flaps have settled in the center.
Yeah.
So that will be the advantage for the urethroplasty in the second stage.
And part of inner preputial skin was excised, sir.
No, very little because it was adherent with that smegma, no? That part I have removed. A lot of things adherent to the smegma particles were adherent there. That much part I have removed. You have a cotton, Gamgee pad.
Dr. Bokal, when
Yes.
you were dissecting the two lateral flaps
Yes.
to expose the body,
Yes.
would you always prefer a number 15 knife, or
Yes, 15
or a round tip scissor is
I
more
prefer
protective?
knife. I prefer knife, and then whatever excess I use the scissor.
Because that plane is very delicate
Yes.
between the corpora and the body. So blind tip, I feel it will be more safer, especially for the beginners.
Yeah. If you are using the loop, you can get a good layer
Yeah, of course.
of a plane there.
Everything has to be done under magnification, preferably. Yeah.
I'm going to give a gentle dressing here.
You do not see the epidermis all along, and this last suture which I took is intermittent, and I would like to show that there is adequate space even after the stent is gone. So we can see that there is adequate space. There doesn't seem to be any constriction or a hole opening. There is still, I am able to pass the forceps and adequately go and enter the tube. So we'll keep it just like that. And I think first thing is we fix the stent. Can you put some normal saline on the tissue system? It's better to keep them wet. Now some people they put the darters below the glans, but there is a constriction which can occur. So I prefer that we'll not use that. I'm just trying to see if there is an adequate spongiosa for the spongioplasty. You can see there are some tissues here. So maybe a suture or two I can take very gently without causing a compression to close as a second layer.
We do not reconstruct corpus spongiosum within which the urethra lies, and that is the muscle force which helps physiologically to propel the urine as well as the semen. So more proximal is the urethral opening, longer is the reconstructed urethra without corpus spongiosum.
Yes, sir.
And therefore, scientifically, the propelling force will be lesser and lesser as the meatus goes down and down up to perineal. And it will be a good study, both the surgeons I'm talking about, that if you do an uroflowmetry,
Yes, sir.
it will be scientifically very interesting. I just gave you an incentive to think of.
Yes. Sir,
In same age group, normal child
Yes.
and in reconstructed child.
Yes.
And if you compare, I'm sure scientifically it will be. Although functionally,
Yes.
our patients having proximal penile or scrotal or perineal hypospadias, they got married and had several children.
Yes.
That's another issue. But scientifically, if you analyze, there will be difference in the uroflowmetry finding.
Yes, sir. In fact, we have been doing annual follow-up of patients. So we are doing a uroflow, post-void residue, serum creatinine, urine routine, and then we've seen that the uroflow is compared to the normal population is slightly on a lesser side, but we need to accept it because the circumference of the phallus is also lesser, the caliber of the urethra is lesser as compared to the normal children. And so when we do secondary procedures with the urology colleagues, we do the scopies, and then they have to use ureteroscope because they can't use the cystoscope in hypospadias operated patients because the caliber of the urethra and the phallus is overall less. So we accept the uroflows to be slightly lower than the same age children. So we've done around 30% of our cases do turn up for the annual follow-up, and it has increased over last 5-6 years. Otherwise the dropouts were very high once we operate the 2 stages and they go home.
Yes, Dr. Jiten will become world famous.
Sir.
And he will be able to reconstruct the corpora cavernosa, corpora spongiosum.
Pardon, sir?
Corpora spongiosum. You will become world famous when you will be able to reconstruct by some technique which you can think of.
Spongiosa
reconstruct
is
the corpus
most
spongiosum.
difficult, sir. Most difficult. Most difficult task.
Think of it.
In fact, someone has suggested to use the dermal matrix in cases where we have in place. So,
Any role of bovine pericardial pads, sir?
So that's what last time they said ki why don't you try as an interposition before you put the darters and see. I mean, you do the urethral reconstruction, put a dermal patch and then do the darters and come out whether the fistula rates will go down. So they are very expensive material unless Pawan has come out with some material which he says is more economical. We'll see if we can use that. So 3 sutures for the granuloplasty will configuration of the glands, and aesthetically also this becomes very good. The tissues, they are very thin, and so that is the reason we prefer to operate these children around 3 to 4 years and not earlier, because the tissues are manageable and even they are more better for the anesthesia purpose compared to the Western population where the birth weights are good and they tend to operate much early in life. Our duration is around 3 to 4 years, and we feel that preschool we should finish all the stages if there is a fistula or if you do stage procedures. So
how do you decide the amount of dissection proximally?
yes, sir. So most
which
of
you have
these
already,
yes,
you have dissected
somewhere
almost.
around the root. So sometimes when you do the deglowing, you see that there is a flimsy adhesion at the urethra proximally. So I prefer to go somewhere around mid to proximal penile for the dissections. And then we used to do what Professor Snodgrass used to do as a dissect the darters from the skin and use. But then we had a lot of ischemic skins and sometimes necrosis. Though they healed conservatively, we do not prefer to do a lot of deglowing at the darters and skin level. I'll just show when we take this Bayer's flap like thing. So can you put some normal saline sister? So the granuloplasty is done. Now you see that this tissue which is slightly in excess, I'm going to trim finally, minimally, and we'll fix the stent. Can you take out the stage suture? So can you give me needle holder?
Any sutures, or you just tag it?
Yeah, I prefer to take not very tight sutures, 2 or 3 are enough. Depends on the length, how much you have. No, it's like, no, slightly push it in. Push it in till this mark. Now the urethral stents, there are 3 sizes available in India, 6, 8 and 10. So generally we use 6 to 8 in children and in adults 10. So beyond this there are no sizes available for the urethral stents. And one question which comes for the postgraduates is, suppose the stent slips off. Sister, can you come on this side and hold this? in the first 24 hours. So what we prefer to have is take the patient to theatre under anesthesia. The operating surgeons should try to glide the stent, and it does go in. It does go in. And then if it doesn't, then you put a SPC. There is no manipulation to be done. 1 or 2 try with jelly under anesthesia, never in the wards.
I think for the distal penile hypospadias type,
Yes, sir.
it should not be a problem to renegotiate
Yes,
it.
yes, yes. We
It's
can.
not a long segment.
Yeah, yeah.
Sir, we have seen that sometimes they used to suture the urethra, tubulize the urethra with
Mosquito.
8-number feeding tube and then remove that and put in 7-number feeding tube.
Actually, I mean, it's a personal preference. Frankly, the stents, they are acting as a urinary drainage conduits. They are not related to what size of the tube you are making. Okay, so you may put a 10 French stent. Doesn't mean that your urethra caliber accommodates that. It is much bigger when you make a 10. So 6 French, if it is accommodating, 8 is accommodating. It is just for urinary drainage.
Actually, that change of stent which you are mentioning
Okay.
is to take care of the edema. See, intraluminal edema is also
Yes,
there. There is
yes,
raw
yes,
area, especially in the snodgrass.
Yes.
So there has to be some edema. So let the edema get space to develop. Otherwise, it puts its strength on the reconstructed urethra and the skin, of course. So there is no harm in replacing white.
Can you put the other side? The outer one. Okay, take it. Symmetrical. Now, if you see, you can dissect between the 2 layers here and use the dartus fascia separately. So there is a foamy layer in between the subdermal plexus and this fascia. So I prefer to retain this and use it along with the skin like we do the Bayer's flaps, because we found that the skin becomes much robust then if you maintain this slight stretch. Yeah. So I'm just demonstrating the hand at the. Is it okay? Can you show this down?
Zoom out, sir.
Light here, light दे थोड़ा. ठीक है?
Yes, sir.
Now lift up the flaps. So this is midline, dorsally, and I'm just seeing that we are comfortably. We are not going to pull the skin. We are pulling the phallus. So the skin should drape very comfortably. Okay. So there is adequate laxity here. We don't trim it beyond this. Suture 5, PDS 5. Take this flap. Then hold this flap. Now this is the plane in which we can dissect if you want to dissect. Can you see this plane? Can you lift it up? Are you able to see the plane?
Yes, sir.
So this is the plane of foamy layer where we dissect and go and use this separately. But we found that the chances of having skin necrosis, the epidermal necrosis, are more if we do a lot of dissection. Now here again we have to see that we suture it at 12 o'clock, because otherwise there is a torsion if you do not suture it at 12 o'clock. Sister, इकडून येतो. Okay. Now we'll see that the tissues are well vascularized and these flaps are coming in. We have both the flaps. We have the darters here. Okay. So at this stage I would like to release the tourniquet and see if there is any oozing. And then if there is any, I will reapply because you will be able to see better. Saline soap boss, saline soap without squeezing. Squeeze na karta na पिळता. So I don't think there is any active bleeding or any oozing here. So it
that proves that you are in the correct plane.
yes sir, thank you sir.
So it is very essential that you know which tissue you are cutting, at what plane, because all over the body, God has given beautiful bloodless fields.
Yes.
And your surgery and the result becomes easy anywhere in the body if you have entered the correct plane from the beginning of surgeries.
So now this glans tissue, if you retain, there are chances of having a fistula here at the corona. So can you hold this for me? So I am trimming the tissues which are hypoplastic right away. And all tissues which we retain should be well supported with the good dermal thickness. So skin which is unsupported needs to be excised. The same principle which we follow for the fistula. Now you see this is a good quality skin which is remaining. And now we'll put the dartus fascia.
See, the surgeon is not bothered in this particular case about the skin shortage because he is going to use the prepucial skin. So
Yes.
you can always trim whatever is not necessary. In some other techniques, this cautions.
Now I am trying to take this below there is one epidermal island which is remaining here, which I am going to take. So I am going to go beneath the glans wings, feeding the fascia, so that the junctional area has a good vascularity and it prevents any fistula formation. So I am putting it below glans wing. And this is going very comfortably without any tension. I will reapply the tourniquet because the field will be better. Because there is nothing which we would like to coagulate at this stage. Can you move please? There is a lot of tissue excess, so we can contour or retain it. In case there is any fistula or you need skin at another sitting, you can use it. You can always tailor it when the child grows up.
If there is a accidental nick, 1 or 2 on the corpora cavernosa,
Yes, sir.
and there is profuse bleeding. So
Uh,
what is your preferred choice?
Yes,
of
I
controlling?
prefer to take immediate suture with 5O and seal it off.
Yes.
More please. Now if you see there is a good vascularized dartus tissue on both the sides. I will take tacking sutures and then do the skin closure. So the moment I am lifting up, this is coming very comfortably. So differential dissection between the dartus and the skin, we are not very happy. So this gives a robust blood flow to the skin flaps, and we are happy about the skin. You see that there is a vascularized tissue on the reconstructed urethra. So this is our third layer. First was the urethral, second was the spongioplasty tacking sutures. This is the dartus, and then we have the skins. So practically we have the 4 layers which are coming up. the theatre case is induced, they can start.
Any indication for tunica flaps?
Actually, if there is no dartus available, then only we should plan tunica. Primarily use of tunica by some for TIP is a overdue, I think. In our series, I think we have done tunica for maybe 1 or 2. So very rarely, even if you have a cripple, there's a good amount of dartus. And the other thing is about testosterone, small note, that in case we have hypoplastic tissue and stretch penile length less than 2.5 centimeters, and there is a definite proof that there is no problem with the assigned sex, then we can give 3 doses of intramuscular testosterone, 1 to 2 milligram per kg, deep intramuscular, once a month, 3 doses. And we found that there is a good amount of tissue which is again good soft tissue and very robust flaps. So testosterone injection we use if there is a doubt about the phallus size, or if the in case of redo also that we want to use, we can use. Why take so long? So as long as the tissues are in approximation without tension, they will heal. Now you see that there is no tension on this skin. They are draped well. Parnitkar sir is there in the audience?
Darak sir is there.
Okay, sir, good morning. Darak sir.
Good morning, Jitan.
Well,
Well demonstrated.
Thank you so much. Sir, actually I want to remind that 25 years back, you had organized with ND sir and Parnitkar sir the Hypospadias Workshop. So I think it's been a long time for our city to have, so we thought we should have you also in the audience as well as Parnitkar sir, ND sir. So we have a long.
So he used to use quite large scissors,
Yes.
and we used to wonder that cutting so thin tissues and delicate tissues, but his results were excellent, of
Yes,
course.
sir.
And as you said, he won't put too meticulous stitches.
Yes.
As far as reconstruction of urethra is concerned, he will. Later, it will just heal. It's a very vascular structure.
Yes.
But even now, we don't dare to do like that. But that used to happen. I have assisted him several times in the workshops.
Yes.
So I never had the guts to ask him also on the table. But later on, when very politely I asked him, he said, "Don't worry, it heals."
Yes. And Snodgrass, suppose once you've done the procedure, the child is passing urine comfortably. There are some centers who are using after 3 months calibration, or under anesthesia they do 6 French or 8 French calibrations after 3 months. So the stream improves substantially with that. So probably it goes to show that because you are leaving a small raw area there, and the stents will act as a dilation. So 1 or 2 sittings after 3 months and 1 at the 6 months gives excellent results.
And when you remove the stent, sir?
I prefer to keep the stent for 10 days. You lift the give slight traction on it. Yeah.
It's Mukul sir, second case ready.
play any video, Mangesh, there? Or maybe that YouTube wala.
Dr. Jiten, do you have any preference of suture material for this stage, or you continue with the PDS?
No, sir, this is rapid Vicryl 6
This is rapid Vicryl
6
6
Yes, sir.
So, do you prefer sometimes Proline also? Or this is your choice?
No, sir, Proline I use only if I am doing a dorsal plication. Otherwise, PDS for the urethra and dartus, and rapid Vicryl for the skin.
Right.
Dr. Jatin, I'm Dr. Ansari from audience.
Yes, please.
I want to, know as a pediatric surgeon, we are very fond of keeping this furnished collar. You have trimmed it. Then saying that this is
No, I have not-
unsupported.
No, I have not trimmed the collar, I have removed only the skin part. If you see this tissue, I will just show you. This tissue is there. Can you see this tissue, which is robust? This is one of the very important robust tissues. I have only done the epidermal trimming. If you see, this epidermis I am just removed. Because that is a important, so I said na, the supporting tissue is important. This tissue which is just very flimsy, unsupported, that only we have removed. Because it is a very